Hi, my name is Anna Ibele. I'm an associate professor of surgery at the University of Utah, and I'd like to thank SAGES for the opportunity to present today. I have no disclosures. So when I am in my benign foregut clinic, talking to patients and residents and students about the etiology of reflux, typically there are a few things that we're investigating that potentially can be contributing factors. We're thinking about esophageal clearance and assessing this and how it might be contributing to regurgitation and dysphagia. We're evaluating the function of the lower esophageal sphincter and its relationship to the hiatus. We're thinking about gastric emptying issues and anteroperistaltic coordination, and then the overall global motility of the patient. So are they on chronic narcotics? Are they constipated? For reflux after bariatric surgery, all of these issues are important, but there are also some other factors that can play a role. So behavioral things, how the patient is eating, whether or not they're separating their solids and liquids and chewing, etc. The nature of the operations themselves. So sleeve gastrectomy is potentially a refluxogenic refluxogenic operation, and I'll talk about that in a little bit. Surgical pathology at the gastric outlet and relative obstruction there can play a role. Abnormalities of bile transit and bile reflux and distal obstruction can also be contributing factors. For an overview of this talk, I'm not going to spend time really talking about reflux after band, although I would stress it's important to do endoscopy and to obtain imaging to assess these patients and not just treat their symptoms. Similarly, I'm not going to talk about BPD and kind of some of these other less commonly performed operations in the US. I'm going to spend most of my time talking about reflux after sleeve and reflux after gastric bypass. So for reflux after sleeve, really, there are a few things that can be contributory. So this has generated a lot of discussion recently among esophagologists, foregut surgeons, gastroenterologists, bariatric surgeons. And reported rates of reflux, depending on how you measure it, vary study to study, anywhere from 6 to 28%. There are definitely behavioral factors that can contribute. Patients eating a lot of bulky carbs, carbonated beverages, tough meats, not separating their solids and liquids, not chewing thoroughly, etc. But there are also some innate physiologic things about the sleeve, alterations in the lower esophageal sphincter, changes in receptive relaxation that are conveyed by excising the stomach, as you see here. And then some anatomic things can play a role. So the presence or absence of a hiatal hernia and whether or not that was repaired intraoperatively, dissection at the base of the left crus. If you're over dissecting there, the staple line can migrate up. Strictures and narrowing at the incisura, retained fundus, and bile reflux all can play a role. Just to give you kind of a visual of some different things that I'm thinking about when I'm thinking of reflux after sleeve. Narrowing at the incisura can definitely do it. If it's mild, it can be kind of just reflux symptoms that a patient presents with. So here's a picture of a nice sleeve, making an effort to avoid the incisura, and a nice completion endoscopy where you see that this is wide open. And then here's the completion endoscopy that I don't want to see. So this is a patient that presented to my clinic with a history of sleeve done abroad and pretty severe reflux in the setting of a chronic leak. In their endoscopy here, you see a very tight stenosis at the incisura with bile refluxing up. And on cross-sectional imaging over here on the right, the fundus is very dilated and lots of retained fundus proximal to the sleeve with reflux up into the esophagus. Retained fundus can also be more subtle and can be kind of a late cause of reflux. So here's another patient who presented to my clinic. She'd had a sleeve 7 or 8 years ago and said it went very well. She didn't have any heartburn symptoms post-operatively initially, and then gradually over the 2 years prior to presentation, she had begun to have heartburn, but also pretty significant regurgitation and a feeling of food kind of sitting right in her epigastrum. And I got her operative notes and read them. There was no hiatal hernia repaired at the time of surgery. I thought initially maybe she had one that was missed, or so I got an upper GI X-ray and I didn't really see a hiatal hernia. And then I did an endoscopy, and you can see her in the endoscopic image to the patient's left. There's kind of this very wide sort of retained fundus, and this was actually kind of acting like a dependent diverticulum. So I found food at the base of this, and indeed the endoscope kind of preferentially went into this blind lumen of fundus and not into the alimentary lumen, which is to screen right. So this was kind of a source of the patient's regurgitation. And we treated this by re-sleeving this area, trimming off this piece of retained fundus. Here's another patient. This patient had a sleeve gastrectomy and hiatal hernia repair, and pretty soon after surgery developed some heartburn that was treated with medication, but this worsened over time. And so here's an upper GI x-ray on the patient about a year out from surgery, and she's got this recurrent hiatal hernia that you can also see here endoscopically. Not only was she having heartburn with this, but she was having some pretty significant solids dysphagia, which attests to the fact that for sleeve, when a patient has a small hiatal hernia, if the recurrence is small, the diaphragm can really externally extrinsically compress the sleeve and deform it a little bit, making it hard for solids to traverse. So this patient was offered hiatal hernia repair alone and hiatal hernia with conversion to gastric bypass. As she had not lost all the weight that she wanted to lose, we ultimately converted her to a gastric bypass and fixed the hernia, and her reflux resolved. So with that kind of anatomic overview, my algorithm for initial evaluation and management of reflux post-sleeve is I take a pretty careful dietary history. I have the patient journal, do a diet log, and correlate what they ate with their symptoms and the time of onset. And then if there's anything that's contributory to reflux there, we do some behavior modification. I'll give a patient a trial of proton pump inhibitors, but I'll follow them up closely. So I'll usually start PPIs and have them follow up in about 6 months, and 3 months, and then try to wean them over time. And for people who fail to wean, for people who really have reflux from the time of surgery onward that persists beyond 3 months, or for people who have had an uneventful course after the sleeve and suddenly start to have new reflux complaints and aren't able to wean off PPIs, I do endoscopy for all of those people. There's a lot of dialogue going on right now with SAGES and the ASMBS and the AGA, talking about whether or not patients should have endoscopic surveillance routinely after sleeve gastrectomy for late complications like Barrett's esophagus. I'm not going to go into that in this talk, but I'm watching that with rapt attention. That's something that is likely on the horizon, or at least a consensus statement of recommendations for us about these types of things. But in general, for reflux that's persistent after sleeve, my threshold to scope is pretty low. And that's because I'm looking for anatomic factors, and I also want to rule out Barrett's esophagus or severe LAD esophagitis. As an adjunct to endoscopy, upper GI and CT are both very helpful. Upper GI will demonstrate recurrent hiatal hernia, is good for showing stenosis in the sleeve. CT I found to be really helpful for small hiatal hernias. Coronal imaging on the CT can show that the staple line has migrated slightly above the diaphragm, and that may be very subtle on an upper GI x-ray. And then for patients where the clinical picture is still not clear, or patients that I'm thinking about taking back to surgery, I'll get manometry on people for a baseline, and then pH testing to make sure that if I haven't found an anatomic etiology, that pathologic reflux is really the thing that I think that I'm treating. Gastric imaging studies kind of plus minus. These aren't always particularly helpful. I think in some patients it's useful to examine the images if you think there's a stenosis and see if the radiotracer is hanging up. I've really only found them to be helpful if they demonstrate delay, because usually they're rapid, right? And then treatment, so I think it depends on what you find. Behavior modification, PPI, if there's not Barrett's, and the patient doesn't desire surgery, you want to be careful about endoscopic follow-up, in my opinion, for these people. For anatomic things, so long segment strictures, seromyotomy has been described. This is kind of variably effective. Hiatal and paraesophageal hernia repair, you really have two options. You can re-repair a recurrent hernia or repair an initial hernia, or you can do a repair and convert the patient to gastric bypass. And I think that decision, is for me a lot of conversation between myself and the patient. Thinking about why they had the sleeve in the first place, If they had a sleeve and a big paraesophageal hernia repair and it's failed, I'm much more likely to convert them to gastric bypass with the hope that that will be more durable for them. Excising dilated fundus or re-sleeving the sleeve. In the case of my patient there with a big dependent retained fundus is sometimes effective. Radiofrequency ablation has been studied and isn't very effective. Magnetic sphincter augmentation is a topic of some discussion right now, and there's some international and industry-sponsored trials going on. And then conversion to gastric bypass, which I found in my own practice to be very effective for a lot of the anatomic issues that cause reflux after sleeve. So just to very briefly review data here to stay on time, seromyotomy, here's a small case series for long segment strictures in 8 patients. Half of the patients improved, 1 leaked, 1 got converted to bypass. Radiofrequency ablation, you can see not very effective here in changing scores, patients not very satisfied. Magnetic sphincter augmentation in small case series shows a lot of promise in both subjective and objective testing. And then conversion to gastric bypass, here's a nice, relatively large case series out of the Middle East of 47 patients who underwent conversion of sleeve to bypass for a variety of complications, 21 of whom had intractable reflux as their main reason for conversion, and 17 of those patients out of the 21 completely resolved their symptoms at 17 months post-op. Moving on to reflux after bypass. The algorithm is a little bit different. So I will have patients do a dietary log and assess for behavioral factors and do some dietary modification. But really, I'm very quick after a bypass to go looking for anatomic factors. And I think it's because this operation innately is something we use to treat reflux, right? People shouldn't be having reflux after a bypass. So I typically don't, trial them on a PPI. I might put them on a PPI if I'm, waiting on an endoscopy or further workup. But really for patients who have persistent symptoms, I'm going to go looking for anatomic factors. So things that can be potential causes, hiatal or paraesophageal hernia, a large pouch with lots of fundus and parietal cells, stenosis at the gastrojejunostomy causing relative gastric outlet obstruction, Gastro-gastric fistula, a short Roux limb with bile reflux, and partial obstruction of the Roux limb or partial small bowel obstruction can all cause reflux. So for kind of a visual tour of some of these anatomic factors, here's a woman who presented to my clinic. She had gastric bypass over a decade ago, had some bad ulcer disease that was treated and that she ultimately healed. And then she wound up in one of my general surgery colleagues' clinics thinking about a hiatal hernia repair. And he very appropriately realized that hiatal hernia wasn't the only thing going on for this woman. So you can see she has a hernia, but she's also got a very large gastric pouch with kind of this tightly stenotic outlet on her CT there. And endoscopically, this is what it looked like. So she has this sort of offset anastomosis with this kind of chronic sort of fibrotic tissue and this tight stricture. And we attempted to dilate this a couple of times, I think because it was so chronically fibrosed, probably from her ulcer disease. She didn't respond to that very well. Other things, that I typically do with strictures, we talked about, so, making sure she wasn't on NSAIDs, tobacco, and even a vaping history, just because we don't really know what's in it. Steroids, she had none of these risk factors. And so having failed endoscopic dilation and a trial of PPIs, which she'd actually been on for some time, we revised her anastomosis and downsized her pouch and fixed her hiatal hernia, and she did very well. Here's a nice picture of a very big gastrogastric fistula. This patient presented with epigastric pain and reflux, both I think from gastric outlet obstruction, as the fistula there is actually larger than the gastrojejunostomy, but also from reflux coming up from the remnant stomach, which is no longer divided in this non-divided bypass patient. Hiatal hernia is an interesting entity in gastric bypass. I have seen patients with small hiatal hernias who don't have them repaired at the time of surgery and really don't have symptoms. And potentially there's some advantages of not doing that mediastinal dissection and taking down the phrenosophageal ligaments for very small hernias. That hasn't really been well studied though. But typically, the patients that I see who are symptomatic with hiatal hernia post-bypass are those who had big hiatal dissections and recurred, are people who have hernias that are big enough that the pouch has actually become folded or torsed, or the anastomosis is sitting at the diaphragm with diaphragmatic impingement on the anastomosis. So here's a gentleman, endoscopically, you can see kind of his bad esophagitis. He has a small gastric pouch. He'd had a paraesophageal hernia repair and then had a recurrent hiatal hernia. And when he does a deep inspiration, the pouch and the distal, or the proximal part of his gastrojejunostomy are actually pulled above the diaphragm. He had presented with heartburn, but also epigastric pain and regurg, and had this relative pouch outlet obstruction from his hiatal hernia. So we repaired this, and he did very nicely. Other things to look for, so bile reflux in the setting of a large pouch. Here is a patient who has both problems and required revision for this. Bile reflux should always make you think about a short Roux limb or some kind of distal obstruction. So adhesive disease can do it. Patients with gastric bypasses done a decade or two ago, the Roux limb tended to be shorter. Endoscopically, when you're looking for this, it's nice to try and drive down to the JJ, but you shouldn't see bilious refluxate in the pouch or get a history of this from the patient. You can trial cholestyramine for people in this setting, but really the definitive management if the patient is an operative candidate is Roux limb lengthening with reimplantation of the biliopancreatic limb. And then finally, in the differential of reflux after bypass, chronic partial obstruction should also be something that you're thinking of. Here's a patient who presented with reflux, but you can see from the CT scan here what's really going on is she's got kind of this chronic obstruction distal to her JJ where her Roux limb is dilated up and she's experiencing reflux from stasis. So in summary, when I'm thinking about reflux after bariatric surgery, I try to take a careful history, get a patient to do some dietary journaling, assess the timing and nature of the reflux and behavioral factors. But then I think pretty quick low threshold, evaluate their anatomy, get an endoscopy, look for surgical pathology, particularly if they have a sleeve to rule out Barrett's, particularly if they're experiencing dysplasia. I've seen some imaging, upper GI and CT. And then you can try the patient on behavior modification, PPIs and Carafate, closely follow them up. But really, I think if they have anatomic pathology, or if they have Barrett's esophagus in the setting of sleeve, and they failed medical management, you should be, pretty low threshold to offer surgery with definitive revision, unless the patient isn't an operative candidate. Endoluminal therapy, I think magnetic sphincter augmentation is interesting and shows some promise. I would offer this currently right now only if the patient was a poor operative candidate or there was no identifiable anatomic cause and no revision that could address their reflux. More long-term studies are needed here, really. So thank you, Sages, for the opportunity to speak. Everybody stay well out there, and I hope to see lots of you in person next year. Thanks very much.